Hello, everybody. My name is Daniel Ciampi de Andrade. I'm speaking from São Paulo, Brazil. Welcome to COVID-19 Pain Virtual Program Part 2. In Part 2 of our program, we will be talking about long hauler COVID-19, pain morbidities, and their management. We have this very nice program trying to cover several interesting basic science and clinically oriented topics on what we have learned so far from COVID-19 with a focus on chronic manifestations of the disease. We will start by the first presentation. I would like to introduce you Brian Wallet, who's also co-chairing this part 2 virtual program. Brian is a rheumatologist who serves in many different roles in the National Institutes of Health, NIH. He serves as medical officer for both the National Institute of Nursing Research and the National Institute of Dental and Craniofacial Research. He also serves as the lead associate investigator on the National Institute of Neurological Disease and Stroke, myalgic encephalitis, chronic fatigue syndrome at NIH, and natural history of post-COVID-19 convalescence at NIH protocols. He's also recognized for his academic work with fibromyalgia patients. Hello, Brian.
Hi there. All right, well, I guess I'll take over. Our second presentation will be entitled Post-COVID Syndrome and Chronic Pain, How to Name It and How It Looks So Far. And our speaker for that will be Daniel Ciampi de Andrade. I think I got that mostly right, who you can see has already spoken to you today. Daniel is a neurologist specialized in pain and attending physician at the Hospital de Clínicas São Paulo, Brazil, where he coordinates the institution's neurology department pain center. He is also dedicated to pain research and education and is currently the coordinator of a 12-month pain residency program for neurologists and neurosurgeons, and is the vice leader of the Medical Research Lab 62, LIM 62, one of the medical research groups from his institution. Our third presentation is from the FAIR group and is entitled Fair Health Analysis of Post-COVID Conditions. The talk will be given by Robin Gelberd, who is the founding president of Fair Health, which is a national independent nonprofit organization that serves as a trusted leader in healthcare cost transparency, data analytics, and benchmarks. Fair Health possesses the nation's largest collection of private healthcare claims data, which includes over 34 billion claims records and grows at a rate of over 2 billion claim records a year. They are certified by the Centers for Medicare and Medicaid Services as a national qualified entity. Fair Health also receives data representing the experience of all individuals enrolled in traditional Medicare Parts A, B, and D. And Robin herself is a nationally recognized expert on healthcare policy and health literacy and transparency, and has been selected as one of Crane's 2019 Notable Women in Healthcare. Ali Russo will be assisting her in the questions and answers, and she also has 25 years of experience in various aspects of information technology, including more than 20 years in healthcare data analytics and product development. Prior to joining Fair Health, she was with McKesson, where she also had multiple roles, including responsibility for the analytics services under the Health Solutions Division. As Director of Analytic Services, she focused on bringing actionable analytic information to the healthcare sector based on allocated claims data. Ali received her BS in biology from State University of New York at Albany. And as you can imagine, we're going to hear a lot about how health claims data can help us understand the consequences of COVID. And with that, with no further ado, we should get started with our first presentation. Hi, my name is Brian Wallet, and the title of my talk is Exploring the Post-Acute Sequelae of COVID-19. I have no conflicts of interest to report. I think the entire audience is pretty familiar with the virus that is pictured here. The SARS-CoV-2 pandemic has touched all of our lives. The ramifications on morbidity and mortality are going to follow us for years to come. And the purpose of this conference is to talk about those complications that we can expect, especially in particular, those related to pain. I would like to introduce the term post-acute sequela of COVID-19, or PASC, to the audience. It is defined as the persistent symptoms, delayed recovery, and long-term complications that occur beyond 4 weeks from the onset of a SARS-CoV-2 infection. And this umbrella term is used to capture everything that follows a COVID infection. And so what can we expect to follow COVID? And those expectations can be anticipated by sort of reviewing the main physiological mechanisms that COVID-19 causes injury to humans. And so the first main arm of impact on humans that COVID has is its ability to directly trigger inflammation. The inflammation from COVID-19 is obvious enough to cause severe tissue injury in some individuals, and the inflammation itself can persist after the acute infection resolves. And this may be related to all sorts of differences in host factors. There can be differences in how different people have their innate immune systems respond, either through excessive monocyte or macrophage activation, or even excessive inflammasome activation that leads to persisting problems. There are also known systemic immune response differences between people. Systemic cytokine imbalances have been reported, in particularly the cytokine storm of COVID-19. And there's interesting stories about how adaptive immunity can fail some individuals. If you're not familiar with the anti-interferon gamma antibody story, it's worth looking up. There can be differences between people in how their immune systems regulate and restore after injury. And some of these problems could lead to persistent COVID-19 independent inflammation that has been reported, or even the development of autoimmunity, as we see with children with the multi-system inflammatory disorder. And there are some theoretical possibilities. The idea of persistent viral reservoirs is certainly one that is of interest and is not yet quite resolved. Persistent viral reservoirs have been seen in cases like an Epstein-Barr with chronic Epstein-Barr infection syndromes. And incomplete viral assembly is also possible, as we see with measles. And these can potentially lead to long-term complications. The second major arm of injury that COVID can cause is thrombosis. And it's quite clear that the infection can directly trigger thrombosis in a variety of ways, and that the complications of the ischemic injury of thrombosis are really well known and well documented. There are a number of ways that COVID does induce thrombosis. It can do so through direct endothelial injury through ACE2 receptors, the inflammation activation of clotting cascades via tissue factor can lead to clotting, complement activation can lead to clotting, and antiphospholipid antibodies have been shown to develop in some individuals with COVID-19 that can also lead to clotting. The third major arm that can lead to alterations in humans after COVID are fear, stress, and change. And the pandemic itself has been a source of all three of these for all of us, even those that have not been touched by the virus. We have all been physiologically impacted by the alterations in our lifestyles from COVID-19, and these make us all more vulnerable to chronic illness. And some of these changes manifest themselves through effects in the endocrine system, with alterations in the hypothalamic pituitary axis. In general, people tend to become hyperactive in that way, but hypo-responsive to new stress. We see changes in the autonomic nervous system that are similar. There can be alterations in the immunological system with alterations in Th1, Th2 homeostasis. And then there are a variety of stress-related illnesses that can occur in people in these situations. For those who are sick and go to the ICU, there's critical illness and post-ICU stress disorders. But fear, stress, and change have been associated with cardiovascular disease, asthma, dysautonomia, and a variety of neuropsychological illnesses. What we can expect is to see a variety of post-acute sequelae of COVID-19 subtypes. The major four that I believe we will see will include a cardiac subtype, a pulmonary subtype, a neurologic subtype, and post-viral syndromes. The first three are pretty well defined and characterized by medical science, and we can expect the inflammatory ones to be things like myocarditis or pneumonitis um, or neuronal inflammation, the thrombotic complications to be heart attacks, pulmonary emboli or strokes, and there was recovery that follows that. And then we're going to see functional issues in those three systems, including arrhythmias, reactive bronchoconstriction, dysautonomia, and neuropsychological sequelae. Post-viral syndromes, however, are less well defined medically and include a variety of things, including the post-viral fatiguing syndrome itself, myalgic encephalomyelitis, chronic fatigue syndrome, headache disorders, and fibromyalgia. What is important to realize that all four of these subtypes can lead to similar phenotypes of pain, fatigue, exercise intolerance, weakness, altered sensation, altered cognition, and altered personality, and that these subtypes themselves may not be mutually exclusive. There's no reason you can't have more than one. I'm going to take a moment, though, to talk about the least defined of these four, which is post-viral fatiguing syndromes. The post-viral fatiguing syndrome was initially described in 1985 by Behan and Behan. Its principal symptom is severe muscle fatigability, but there may be a range of secondary symptoms such as the aching of muscles, disequilibrium, and psychiatric manifestations. And there have been a variety of prospective studies to understand post-viral fatiguing syndromes. The first conducted in 1996, the UK viral meningitis study, which followed 159 confirmed viral infections over 6 to 24 months. And they found that over that period of follow-up, the prevalence rate of meeting CFS criteria, chronic fatigue syndrome criteria, was around 12.6%. A second study in Dubbo, Australia, done in 2006, followed 253 confirmed viral infections over a year. And what they found is, regardless of the infection at 6 weeks, 35% of their cohort met CFS criteria. That number dropped to 27% at 3 months, 12% at 6 months, and 9% at 1 year. And there has also been survivor studies from SARS, which is yet another coronavirus, and probably very important in understanding what to expect. And in their study of 181 survivors over 41 months, 15% reported pain disorders by the end of their surveillance, 40% reported persistent fatigue, and 27% would have met CFS criteria. History strongly suggests that a post-viral fatigue will be a substantial problem for the SARS-CoV-2. So let's do a little bit of math. As of August 26, 2021, there have been around 214 million cases of COVID-19 worldwide. If we use the Dubbo study as an example of what to expect, at 3 months, we would expect around 74 million cases of post-viral fatigue. This would drop to around 25.6 million at 6 months, and at a year, 18 million people will be having post-viral fatigue problems from their COVID infections. If we postulate that 5% of individuals never recover, that's 10.7 million persons worldwide whose lives have been ruined by COVID-19. These reasonable estimates of the burden of SARS-CoV-2 post-viral fatigue are quite alarming. And so with this in mind, myself and my colleagues at the National Institutes of Health have put together a research study to understand the natural history of post-coronavirus 19 convalescence. And this phase study seeks to look at individuals in a broad way and then use more use techniques that are that drill down into the biology over time. Today, I'm only going to talk about the phase A data, which is collected from telephone interviews and internet surveys. This includes 145 individuals, and you can see the basic demographics are presented here for you. So what were their problems before COVID in this cohort? Well, you can see that some of the things that one would expect, that a lot of people would have premorbid problems with these problems like ME/CFS or fibromyalgia or Ehlers-Danlos syndrome. Very few people really did. Nobody had chronic fatigue syndrome, and 2% of our population had fibromyalgia premorbidly. As you would expect, irritable bowel syndrome, traumatic brain injury, or loss of consciousness from injury, and thyroid disease were not unheard of, but not that common, all around 15% of our population. Issues with anxiety and depression prior to COVID were seen in about a third of our cohort. And unexpectedly, 63% of our cohort described problems with seasonal allergies. In America, we would expect that number to be around 30%. However, altogether, it seems unlikely that pre-existing conditions themselves will explain PASC symptoms in the majority of cases. So what sort of stories are these individuals telling us after COVID? As you can see here, some are back to their usual state of health, and some continue to be as sick with COVID as when they were at their sickest, but those are few and far between. The two most common narratives were that people got sick, got somewhat better, but those symptoms that they had when they were sick never quite resolved, and that was 47 people in our cohort. But the most common story is that people get better and then develop other symptoms that they did not have during their COVID infection that persist and keep them from returning to their normal state of health. What's important to realize is that there will be multiple stories about how people develop their PASC symptoms, and we'll need to take that into account when we evaluate them. In terms of the types of symptoms people have after COVID, what we can see is the symptoms of post-viral fatigue are quite common. Fatigue and cognitive issues are complained about in 83% of our cohort. Unrefreshed sleep is in about 2/3 of our cohort. But surprisingly, exercise intolerance is only seen in about a third of our cohort, exercise intolerance being the sine qua non of myalgic encephalomyelitis chronic fatigue syndrome. However, cardiopulmonary issues are also quite common. Chest pain and shortness of breath at rest are seen in 37 to 44% of this cohort. And neurologic complaints are also not uncommon. Tingling sensations and weakness are seen in over 50%. Autonomic symptoms, such as dizziness when standing, is seen in about half of our cohort. The pain all over, which is the sine qua non of fibromyalgia, is seen in about a third of our cohort, and mood problems in about 2/3 of our cohort. What this suggests to me is that symptom reporting alone will not be enough to determine the subtypes of PASC. And how severe are people's symptoms? So to help illustrate the severity of symptoms, we will use data collected with the patient-reported outcome measure information system, or PROMIS, which was developed to be sort of a standard patient-reported outcome system. You can see here, symptoms can be scored between 20 and 80. Every 50 is sort of average for the population. Every 10 points is a standard deviation. The cutoff between normal and mild disease is around 55. The cutoff between mild and moderate is 60. And what I've done is I've put a black line on the slides to come to sort of show you the edge of where moderate severity is. And so this is looking at fatigue. In the green are our PASC cohort. In blue are healthy volunteers that we have collected as part of a different protocol to study ME/CFS. And in red are those ME/CFS patients that are part of that protocol. So what you can see here all the way to the left are what healthy volunteers look like in terms of their complaints of fatigue. They really don't complain of fatigue at all. To the right, all the way in red, are the ME/CFS patients. Their disorder is defined by fatigue, and every single one of them has at least moderate levels of fatigue. And you can see the distribution of PASC is sort of between that, where there is a pretty wide distribution of mild, moderate, and severe fatigue that defines that population. In terms of sleep impairment, again, all the way to the left are the healthy volunteers. And you can see a wide distribution in both the ME/CFS cohort and the PASC cohort for sleep impairment. In terms of anxiety, all the way to the left are the healthy volunteers, but anxiety doesn't seem to dominate or define either the PASC cohort or the ME/CFS cohort, and their distributions look pretty similar. However, depression is quite different between the cohorts. Again, you can see our healthy volunteers all the way to the left, but our MECFS cohort was sort of cherry-picked to not be depressed. And you can sort of see that they're not. However, depression will play a significant role in understanding the post-acute sequelae of COVID-19. In terms of fibromyalgia, again, our healthy volunteers all the way to the left. And you can see the shapes of the curves of both the MECFS and the PASC cohort are almost identical. And so you can expect that fibromyalgia or the fibromyalgia nests will be an issue following COVID-19. In conclusion, the post-infectious complications of SARS-CoV-2 will impact millions of people worldwide. There will be multiple subtypes of PASC that will overlap. Case validation will be critical for research efforts. Similar clinical phenotypes may have very different physiological causes. Careful selection of measurement tools will enable a description of PASC and its subtypes and enable for comparison to the general population and to other disease states. So I'd like to take some time to acknowledge and thank all the people that I work with, my team 3B19, including Dr. Nath, Angelique Gavin, Anita Jones, Elizabeth Bartram, Jun Yi, Bryce Calco, Sean Haran. I'd also like to thank all the members of the NIH intramural MECFS study team for their wide-ranging contributions. I'd also like to thank the employees of the National Institute of Neurological Diseases and Strokes for their support of my research program. And most importantly, I'd like to thank all of our research volunteers for their time, effort, and offering up their bodies to study. Thank you so much for your attention.
My name is Robin Gilbert, President of Fair Health. I'm delighted to be presenting to you today. In this presentation, we will review findings from Fair Health's recent white paper on post-COVID-19 conditions, with a particular emphasis on common pain diagnoses among patients who recovered from COVID-19. Fair Health is a national independent nonprofit which has as its mission to bring fairness and integrity to health insurance information. We were created out of a national hunger for a standardized, comprehensive, and trusted data source to help all stakeholders exhale and have confidence in the information presented. We meet that need by having the largest collection of private insurance claims in the country and by being prudent stewards of that data. We now have over 34 billion private insurance claims from 2002 to the present. We receive over 2 billion new claims each year. The data are received typically monthly from approximately 60 national and regional payers and third-party administrators and reflect both self-insured and fully insured covered lives. Because of the breadth of our data collection, coupled with our independence, many federal agencies have reached out to Fair Health for assistance with various programs and initiatives. For example, we provide data to the U.S. Bureau of Labor Statistics to assist with the development of monthly medical indices. We serve as an approved source for MedPAC, otherwise known as the Medicare Payment Advisory Commission, to help inform its reports to Congress demonstrating variation between the commercial and Medicare programs. Apart from our work with many federal officials and agencies, we provide extensive and unbiased support to states, serving as official benchmarks in statutes and regulations, as well as providing states with analytics offering keen insights about their healthcare system. As a testament to how our data serve as the basis for public policy and public health interventions, the Centers for Medicare and Medicaid Services use findings from a separate COVID-19 study by Fair Health to inform vaccination protocols for long-term care facilities and intermediate care facilities for individuals with intellectual disabilities. Now let's turn our attention to the data featured in our latest white paper on post-COVID conditions. We drew upon our longitudinal data set to identify all patients who had a diagnosis of COVID-19. The study period ranged from February 2020 through February 2021. In February and March 2020, there was not yet an official diagnosis code used in the United States for COVID. As a result, we used B97.29, which was the code used at that time for COVID-19 under the guidance of the Centers for Disease Control and Prevention. Beginning in April 2020, physicians and facilities identified patients using the diagnosis code U07.1, the code for COVID-19. Roughly 2.3 million patients were initially identified using this methodology, and each patient was given an index date for COVID-19, which was the first date that they were diagnosed with the condition. We then evaluated the history of each patient to assign them with comorbidities using the United States Medicare Chronic Conditions Warehouse designations. Once the comorbidities were established, we removed all patients who had conditions which could potentially confound the post-COVID analysis. These conditions included cancer, chronic kidney disease, COPD, cystic fibrosis, viral hepatitis, HIV, and HIV/AIDS, liver disease, congenital anomalies of the nervous system, and stroke. Excluding those individuals, 1.96 million patients remains in the cohort study. Once the cohort was established, we categorized each of the patients into one of 4 groups. However, for purposes of this presentation, we will speak only of 3 of those categories. We removed the 4th category, which was loss of taste or smell, because our study did not reflect any post-COVID conditions in that category. We wanted to focus today on those individuals and categories that did register new post-COVID conditions in the wake of their diagnosis. Hospitalized patients were those who had an inpatient hospitalization with a COVID-19 diagnosis. Those patients included both patients who had been admitted to an ICU, as well as patients who were inpatients but had not been admitted to the ICU. Symptomatic patients were those patients who did not have a hospitalization, but had symptoms around the index date which may have been associated with COVID, such as sinusitis or cough. Asymptomatic patients were those patients who did not meet any of the criteria for the other 2 categories. It should be noted, however, that we use claims data, and patients who were considered asymptomatic never incurred a claim other than the diagnosis of COVID-19 for the duration of their condition. They might have had symptoms, but may not have contacted the doctor regarding them, and thus did not surface with symptoms in our repository. Each of these patients were then evaluated for 38 diagnostic conditions, which have been identified through literature review, as well as data analysis 30 days or more after their index date for COVID. We also excluded all patients with any of those conditions 30 days or more prior to the COVID-19 index date. For example, a patient who had a diagnosis of malaise and fatigue on December 31st, 2019, a COVID diagnosis on February 20th, 2020, and then another diagnosis of malaise and fatigue in June of 2020 would not be considered in the malaise and fatigue post-COVID cohort. The goal of our observational study was to demonstrate descriptive information and post-COVID condition correlations within those patients who contracted COVID-19. We should note that our data only includes privately insured patients for this study and does not include Medicare fee-for-service or Medicaid patients. I should note, though, that it does include Medicare Advantage claims, which are housed separately in our private healthcare claims repository. Because the analysis was an observational study of those patients with COVID-19, we did not use a control group when we evaluated the post-COVID condition incidence and prevalence. Also, as mentioned previously, this is health insurance claims data, and if the patient did not incur a claim due to symptoms, they were characterized as asymptomatic. As you can see here, patients in the 19 to 29-year age group were most associated with COVID-19 diagnoses, comprising 20.9% of the total distribution. Patients who were 30 to 39 years of age made up 18.9%, 50 to 59-year-olds were 18.7%, and 40 to 49-year-olds were 18.3% of the total distribution. COVID cases were rather equitably distributed by gender, with males making up 47% of the total distribution and females making up 53%. This distribution is different from what we usually see in our claims data, where females typically have a higher utilization of medical services and make up 60% of the overall distribution. Of patients diagnosed with COVID-19 in our database, the largest share was considered asymptomatic. The smallest share of the three categories were patients who were hospitalized with the condition. In almost all age groups, COVID-19 patients were more likely to be considered asymptomatic than symptomatic, except for those patients who were 70 years and older. Pediatric patients had the most pronounced distribution, with 62.6% of that patient population not incurring a claim for any symptoms associated with COVID-19, and only 35.5% having symptomatic claims. The share of hospitalizations progressed with each age group. In the pediatric population, 1% of the patients were hospitalized compared to those 70 years and older, where 15.6% were hospitalized. This graph shows the categories by each month during 2020 during the pandemic. Not surprisingly, in February and March 2020, at the onset of the pandemic in the United States, symptomatic patients outnumbered asymptomatic patients as testing was not widely available at that time. Most patients during this timeframe were diagnosed with COVID-19 because they became sick and or were hospitalized. As testing became more widely available in the United States, the number of asymptomatic patients rose sharply and quickly, surpassed the number of symptomatic patients, reaching levels that were maintained through the end of 2020. Of the 1.96 million patients we identified in the population, approximately 23.2% were identified as having a post-COVID condition newly affecting them 30 days or more after their index date of COVID-19. Almost half of the hospitalized patients experienced at least one post-COVID condition 30 days or more after their index date and after discharge from the hospital. 27.5% of all symptomatic patients were identified with a post-COVID condition, and 19% of asymptomatic patients had a post-COVID condition. The 15 conditions that this patient population most commonly experienced at least 30 days after their index date of COVID-19 and not prior to the diagnosis are listed here. Pain, which includes diagnoses such as neuralgia and neuritis and myalgia, was the number one post-COVID condition diagnosed within the cohort. Pain is also cited by the CDC as a post-COVID condition on its website. Breathing difficulties were the second most common post-COVID diagnosis in our analysis, affecting 3.5% of the study population. This too has been cited by the CDC and other researchers as a common post-COVID condition. Hyperlipidemia and hypertension were of particular interest, especially since the patient population identified with these conditions had never had these conditions associated with them before. These conditions have been observed post-COVID in several other studies as well, including a study published in the Journal of Laboratory and Precision. In that study, the researchers found that total cholesterol was significantly higher after COVID-19 recovery. Hypertension has also been correlated to the post-COVID population in patients with no prior history of the condition in studies by the American College of Cardiology and the American Heart Association. Malaise and fatigue, commonly reported in the literature as a post-COVID condition, was found to be the fourth most common in our analysis. The top 15 post-COVID conditions vary by age group, as seen on this slide. While pain is the most commonly reported symptom post-COVID in all age groups, anxiety is the second most common condition in individuals between 19 and 29 years of age, while it's fourth in pediatric patients and those 30 to 39 years old. Intestinal issues are the third most common in pediatric patients, but 11th in those between 40 and 49 years of age. Of the post-COVID conditions evaluated, most were associated with females as compared to males. That said, however, there were 12 conditions, including death after 30 days, which were most associated with males than females. Heart disease, kidney failure, tic disorders, and cardiac inflammation were among those on the list. Thyroid issues, depression, and migraines and headaches, among others, were most commonly associated with females comprising between 60 to 70% of the distribution. Our data evidenced 3 post-COVID conditions that were almost equally distributed among males and females. Sleep disorders, which include insomnia, hypersomnia, and sleep apnea, were nearly equally distributed, with a small differential associated with claim lines that had an unknown gender. Abnormal organ tests, which include abnormal liver result diagnoses, abnormal cardiac test result diagnoses, and abnormal kidney function test diagnoses, were almost evenly distributed amongst males and females. Hearing loss was also found to be relatively equal in both genders, with 51.1% of females associated with these diagnoses and 48.9% of these diagnoses associated with males. As we noted a few slides prior, pain is the most commonly reported post-COVID symptom in Fair Health's dataset. It is also frequently cited by other researchers as a common post-COVID condition. Using the ICD-10 categorizations and including codes that were reviewed by our clinical team and medical officer, we created a list of specific pain diagnoses that have been reported by COVID-19 patients 30 days or more after their initial diagnosis. 41% of the patients who reported pain after COVID had pain that was considered other and unspecified soft tissue disorders not elsewhere classified, such as myalgia. 40.8% of the patient population who experienced post-COVID pain reported general dorsalgia, such as pain in the neck and lower back pain. 10.6% of the pain diagnoses was related to pain that was not elsewhere classified and included other acute and other chronic pain. Other disorders of muscle comprised the last group of pain diagnoses, with 7.6% of the population presenting with this category of conditions. Included in this category was generalized muscle weakness. Individuals between 19 to 59 years old all saw a roughly similar distribution of patients with pain. 50 to 59-year-olds accounted for the highest percentage of post-COVID pain diagnoses at 21.3%. This age group was followed closely in the distribution by those aged 40 to 49 years, who comprised 20.3% of pain diagnoses. Individuals aged 19 to 29 and 30 to 39 both made up approximately 20% of the distribution. Pain diagnoses were less common among the oldest and youngest age cohorts. Those aged 70 and older comprised the smallest share of pain diagnoses at 2%, while those aged 0 to 18 made up the second smallest share at 6%. Here we are reviewing the gender distribution of post-COVID pain diagnoses. This distribution is consistent with our findings that most post-COVID conditions are more frequently associated with females than with males. Among patients with post-COVID pain diagnoses, 58% were female, while 42% were male. In fact, females made up a greater percentage of post-COVID pain patients across every age group. We see the greatest disparity among 19 to 29-year-olds, with females accounting for approximately 63% of pain patients and males comprising 37%. Those aged 60 to 69 and 70 and over saw a more even distribution relative to other age cohorts. In these older age groups, males made up roughly 48% of post-COVID pain diagnoses, while females made up approximately 52%. Among the other age groups, females captured between 56 and 60% of pain diagnoses, and males comprised between 40 and 44%. If we review the age distribution for these specific pain diagnoses, myalgia, neuralgia, and chronic pain syndrome, we see that all 3 of these conditions are most common among 50 to 59-year-olds. However, we also see quite a bit of variation within this distribution. Patients ages 50 to 59 who suffer from myalgia or general muscle aches and pains after COVID illness comprise 23% of the distribution, while 40 to 49-year-olds make up 21%. Patients between 30 and 39 years of age and 19 to 29 years of age also account for a substantial share of the age distribution for myalgia, with the former comprising 19% of the distribution and the latter having 12%. Individuals between 50 and 59 years of age with neuralgia and neuritis unspecified or unspecified nerve inflammation comprise 25% of the distribution, closely followed by the 40 to 49-year-olds who make up 24%. 60 to 69-year-olds make up the third greatest share with 19% of the distribution for neuralgia. 50 to 59-year-olds make up an overwhelming share of claim lines for chronic pain syndrome, making up 32% of the distribution. Chronic pain syndrome, which refers to pain that lasts weeks, sometimes years, is also the only condition in which 40 to 49-year-olds do not account for the second greatest share. 60 to 69-year-olds do, comprising 23% of the distribution. Claim lines for all of these conditions are associated more with females than they are with males. Myalgia has the largest distribution associated with females with 65%, closely followed by neuralgia and neuritis unspecified, where females comprise 64%. Chronic pain syndrome has a slightly larger share associated with males, with females making up 59% of the total distribution and males making up 41%. Now let's review a few other post-COVID conditions. Cardiac inflammation as a post-COVID condition is quite notable as the age distribution has been skewed to a younger cohort, with 25.4% of individuals diagnosed with this condition between the ages of 19 and 29. Of the mental health conditions which were evaluated as post-COVID conditions, anxiety was associated with the highest percentage of patients after COVID-19 in all age groups. Depression was the second most common and was the only mental health condition that had a higher percentage of patients in the 60 and older age group than the 19 to 39-year age groups. Anxiety and depression have been cited in other research as well and are included on the CDC website as post-COVID conditions. In almost all cases, females are more than twice as likely as males to seek care for mental health conditions post-COVID. Tic disorders, however, were more equally distributed, with 52% of males incurring care for these disorders. In our data, we found that patients who were hospitalized and discharged had the highest percentage of death 30 days or more after the index date of their COVID-19 diagnosis. Symptomatic patients who were not hospitalized had the second highest percentage of death. It should be noted that regardless of age group, patients who are symptomatic but not hospitalized had a higher occurrence of death 30 days or more after their index date than when compared to asymptomatic patients. As you can see here, patients who were symptomatic but not hospitalized had a higher occurrence of death 30 days or more after their index date compared to asymptomatic patients. The occurrence increased with each successive age group. In all cases, males were more likely to die 30 days or more after their diagnosis of COVID. Symptomatic and hospitalized patients who died 30 days or more after their index date differed little across ages and in the aggregate in their average days to death. 19 to 39-year-olds who were symptomatic had an average of 95.3 days from their index date to death, while the hospitalized cohort had an average of 92.5 days. Symptomatic patients between 40 and 59 years of age had an average of 93.6 days from index date to death, compared to the hospitalized group, which is 93.74. Thank you for the privilege of sharing these findings with you and for your interest in this critical topic.
Hello, everybody. My name is Daniel Ciampi de Andrade. I'm glad to participate on this webinar. My talk will be on de novo chronic pain as part of the post-COVID-19 syndrome, nomenclature issues, and current clinical data. These are my disclosures. Well, we've seen and we've been using several names and nomenclatures to designate patients who had COVID and remained symptomatic. The term long haul COVID has been coined in a neurology publication. And for non-native English speakers such as me, this is not so intuitive. So long haulers mean haul would mean a long way, a long path, and long haulers, people who are in this long path of disease, of getting better. So that's the main idea behind this nomenclature. And we also have several other names used by several institutions, such as post-COVID syndrome, NHS, post-acute sequela of COVID-19, PASC. The NIH uses it. Post-acute COVID, post-COVID-19 condition, the WHO uses this terminology. They prefer to use condition, not to link it to any specific disease. Long COVID, short, or late sequela of COVID-19. The CDC uses this. And chronic COVID syndrome. Well, irrespective of the name we use, there are some definitions that will help us understand what's going on. So post-acute COVID-19 would be symptoms that start after 4 weeks from the end of the acute infection. It hasn't been detected any viable replication of the virus after 3 weeks. So after 4 weeks, patients who remain symptomatic would not be still infected. We would be having complications of the infection. So post-acute COVID, 1 month after the end of the infection. And then it's subdivided into subacute COVID-19 from 1 month to up to 3 months. So 4 weeks to 12 weeks. And the term chronic COVID-19 or post-COVID syndrome for symptoms extending beyond 12 weeks from the acute infection, and most important, not attributable to other etiologies. So I like to divide the symptoms into two broad groups based on the clinical presentation from the clinical perspective. One is acute complications leading to long-term effects, acute complications that happen during the hospital stay and then may lead to sequela in the long term. We have several of these complications. One is encephalopathy, which is confusion, disorientation, agitation, and somnolence. 80% of these patients, the cause of encephalopathy is delirium, which is potentially reversible, which is different from encephalitis, which is related to altered mental status, fever, seizures, altered cerebrospinal fluid, focal findings on MRI. Hopefully, very common encephalopathy and very rare encephalitis. And stroke is also in this group. We know that patients with COVID have 1 to 3% of stroke, and it may reach 6% in ICU patients, which is 7 times higher than influenza. Patients with COVID may have, when they're still in the ICU, from 20 to 40% of these patients may have significant cardiac arrhythmias and bacteremia, which happens in 10% of patients, but when it happens, it increases the risk of a stroke by 20%. So a stroke is very common, all types of strokes in patients with COVID. And we also have dysimmune post-viral disorders, such as ADEM, which is acute disseminated encephalomyelitis, necrotizing hemorrhagic encephalitis, and Guillain-Barré syndrome. All these complications are common after regular viruses such as influenza, and they have also been reported after COVID, and they may lead to sequela. Not to mention a very specific topic that will be covered in other talks, which is complications due to ICU stay related to medications, muscle blocks, muscle relaxants, and sedation and immobilization. But we also have insidious long-term complications. Well, acute complications, we're gonna have, for example, stroke in a patient with central post-stroke pain or post-stroke pain. But what about the insidious long-term complications? Here we have complications or symptoms that we will start usually slowly during the acute infection and will remain after the infection. There are some exceptions to this pattern, but that's a general pattern that we see. And some of these insidious complications are common to other viral infections. For example, Parkinsonism, depression, cognitive decline, post-traumatic stress disorder related to ICU stay, anxiety. All these complications have been reported due to other viruses infections in other scenarios, and they also occur after COVID. Even a hippocampal atrophy and cognitive decline, have been reported for a long time. And chronic pain, so varicella zoster virus, Zika, Epstein-Barr, so post-mononucleosis syndrome, which is relatively frequent, and infectious disease specialists often see these patients. Chronic pain after influenza, or in some areas of the world, such as in Brazil, HTLV1 infection leading to chronic pain. But so we know that pain is common. It's been shown several studies during the acute setting of COVID, from 20 to 40% of patients during the acute infection, both patients in the outpatient or inpatient settings, they will have acute pain. And several studies also confirm that after in the weeks following the infection, so in the post-COVID setting, from 20 to 30% of patients will have, in the weeks following the infection, pain. They will suffer from pain. So what about chronic pain? What about pain starting after COVID and being present most of the days and lasting more than 3 months? So one way to organize and name, we have to remember that pain is common in the general population. At least 1/5 of the general population suffer from chronic pain. So sometimes it's hard to differentiate chronic pain aggravated by COVID and new de novo chronic pain due to COVID. One way to organize this idea is to have these 3 classifications that we are proposing. One is to name COVID-19 unrelated pain for patients who had chronic pain, for example, migraine or low back pain or fibromyalgia. They had COVID and the pain was not affected by it. These patients exist and they must be named so. Another scenario is those patients who have chronic pain, and during COVID-19 infection, they have aggravation of their chronic pain. So that they have the same chronic pain. These are migraine patients who have more migraine attacks during the infection. And a different scenario is those patients who do not have chronic pain, and they develop chronic pain either because they started to have acute pain during the infection and remained having chronic pain, or in some scenarios, and this is disputable and needs to be discussed, but some patients start having chronic pain or symptoms not straight after the infection, but they developed it after a few weeks or months of the infection. And that relating this scenario, in this case, where the COVID infection is really difficult and open to discussion. But anyway, it also happens. So we would have COVID unrelated pain, aggravated pain, and COVID-19 related pain. We will be able to classify patients using this approach. And can COVID-19 cause new pain in previously pain-free people? So if so, these are main questions. Which pain syndromes are more common? Is post-COVID pain short-lived? Can it become chronic? How can it be managed? We have questions for a few of these points, and we have answers for a few of these points, but not for all of them. We're going to see this. The first studies that came out were on headache. So we had reports two from Spain, one from Brazil, and one from France. These reports were based, most of them, on retrospective cohorts, but some of them were prospective. Most patients were interviewed by telephone, or they had their medical charts assessed, and some few were interviewed face-to-face. These studies showed several things. One is that headache can affect a significant proportion of patients, more than 50%, during the acute phase and the weeks following the acute phase. So headache is frequent during and right after COVID. And also in these studies, having headache during the acute COVID as outpatient or inpatient, some reports associated acute headache with less death, and also with anosmia. It remains to be confirmed. More than one studies found such an association. But so far, these studies had no controls. They only assessed headache, and they did not assess patients who had symptoms beyond 3 months. So we cannot use the term chronic pain to refer to these patients. And we had no really deep information related to previous chronic pain. We don't know if these patients had chronic migraine and got worse migraine after COVID, or if they had de novo headaches after COVID. So we don't have a lot of information on the prevalence of previous chronic pain in these patients. And another question is, do post-COVID-19 symptoms last beyond 3 months? So the first large study published was from a Chinese group looking at patients, assessing by telephone or by internet, patients who had COVID and were assessed 6 months after the infection, and they classified symptoms as new symptoms if they fulfilled criteria of being newly occurring or persistent symptom, or any symptom worse than before COVID-19 development. And they had several symptoms. Usually fatigue is the number one, with dyspnea, and several of them could be related either to chronic pain or to dysautonomic symptoms. Fatigue and sleep difficulties, number one, smell disorder, and then joint pain, decreased appetite, taste disorder, dizziness, chest pain, myalgia, and headache detected in a relatively small proportion of these patients in this study, but still present and being chronic after COVID. We developed, we published a study trying to answer the question on whether we have chronic de novo pain after COVID. We compared patients during the first wave of 2019, 2020 wave, and we compared them to patients who were hospitalized in the same institution in a different hospital, but they were patients without COVID. So we compared patients who had COVID with patients who were in different hospitals within the same health system without COVID during the same time. And these patients had pretty much the same profile, except for heart disease. The control group had more heart disease because it was a heart institute, and several differences related to ICU admission. Patients with COVID stayed more in the ICU, but the proportion of patients receiving mechanical ventilation was close to the control group. So these are baseline information. And patients with COVID, 10% of them had previous chronic pain. And when we looked at de novo pain, so any new pain, or in patients who had no chronic pain previously after COVID, we found pain being significantly more commonly located on the head, legs, and being widespread in about a fourth of the patients. When we looked at the proportion, 65% of patients had new onset pain, so there were patients without chronic pain, without pain, who had new pain, compared to the control group, which was 11%, and new onset chronic pain. So several of these patients were interviewed after more than 3 months from the acute infection, and we found close to 20% of patients in the COVID group developing new pain or a new type of pain, if they had previous pain, that lasted more than 3 months. So showing that chronic pain does exist, and it would affect a significant proportion of these patients. Well, looking specifically at headache, de novo headache was presented up to close to 40% for the patients, and it was de novo chronic daily headache being presented most of the days for more than 3 months in 13% of these patients, against 0 in the control group. Well, these headaches had several characteristics similar to migraine. De novo headache had photophobia, phonophobia, osmophobia, nausea and vomiting in 27 to 40% of patients. It was frequently unilateral, pulsating, and with neck irradiation, and it was aggravated by orthostasis, Valsalva maneuver, or clinical routine physical activity in a significant proportion of patients. The patients with COVID were treated with current drugs commonly used for nociceptive pain. So they had common analgesics, NSAIDs, methimazole, which is very commonly used in Brazil, and some of them had muscle relaxants. So another question, well, another very important point is related to the fact that most of these studies, if not all of them, were related to symptoms. So because of the infection of the pandemic, it was really difficult to see patients face to face. So everything we know so far is related to symptoms assessed by phone interviews or questionnaires sent by email. So there's a lot of clinically relevant information that we simply don't know yet because we haven't examined these patients and published the respective data so far. I will present you some data from a clinical study we are conducting, in which we are interviewing and examining with the standardized bedside neurological examination and a few other QST assessments. We assess patients who were in or out hospital during the infection. All of them had infection, had COVID infection. They need to be interviewed after 3 months of the infection. And we are planning to assess 300 patients. And so far, I'm going to show you data from 132 patients. So what about previous chronic pain and COVID? So these are the patients who had previous chronic pain, and how did it go during the infection? So among patients who had previous chronic pain, which is 42 patients, 43, we had 65% who had aggravation of their chronic pain, 24% no change, 5% resolved, and 5% improved. So most patients with chronic pain get worse during the infection, and a few of them will not have any change in their chronic pain. Then we compared patients who had aggravation of their chronic pain, previous chronic pain, and those who did not have any aggravation. And these patients were more or less similar between them. So they had similar age, sex, percentage of hospitalization, percentage of hyposmia or hypogeusia, and fatigue. So these variables were not different between those with previous chronic pain who had aggravation versus those who did not have any aggravation of their chronic pain. Then we looked at de novo pain after COVID. So if you take all the patients we assessed, patients who had new pain comprised 52% of all the patients we interviewed. And 5% of them had this new pain already resolved by the time of the interview, and 47% had this pain persisting. So it's a new onset pain, which was persisting at the time of the interview. These patients, all of them have chronic de novo pain after COVID, because they were assessed by definition after 3 months of the acute infection. And the DN4 was positive in 32%. When we compared patients with versus without new onset chronic pain, so those patients who had new pain with those who did not have new pain, we found similar age, which was about 45 years, percentage of hospitalization, about a third, previous chronic pain, which was about 30%, previous pre-COVID-19 fatigue, they had similar percentages, and time since infection, which was in average 9 months in both groups. But patients with pain, with new onset chronic pain after COVID, they were more frequently female, 81%, 71% had either hyposmia or hypogeusia, and 77% had new onset fatigue. So patients with new onset chronic pain had more fatigue, more hyposmia, and were more frequently female. And the intensity was relatively high. The average pain intensity in the last week from 0 to 10 was 6.8. And the frequency of pain was also very high. So most of the patients, about 40% of them, had pain within the last 30 days from 22 to 28 days. So pain was pretty much present every day on a single daily basis. When we looked at interference, pain interference, these patients had an average of 4 from 0 to 10 on the BPI interference scores, and they had interference in most activities from the BPI interference score. They had very impacted and negatively impacted quality of life. Their current health status from the Eurocall was very high, it was 67 in average. It goes from 0 to 100. So we have as conclusions, can COVID-19 cause new pain in previously pain-free people? Well, with the data we have, yes. We have a lot of data showing that patients without chronic pain may develop new pain that quite frequently is a headache, but it may be leg pain, lasting more than 3 months and being present most of the day. And if so, which pain syndromes are more common? Well, this remains to be better explored, but so far headaches are very prevalent and patients with leg pain are being explored in this study. And we found a relatively high proportion of patients with a positive DN4. Well, the DN4 is a screening tool, but in the general population, it's about 7% positivity. So of course, this type of assessments, we have bias. Patients who had worse COVID or who are symptomatic, they tend to come more frequently to the study than those patients who have no symptoms, but still 32% is relatively high. Is post-COVID pain short-lived? Well, it may be short-lived in some patients. We saw that 5% of our sample had the post-COVID pain resolved when assessed at an average of 9 months, but most patients remain symptomatic. But it may be short-lived. Can it become chronic? Yes, it can. And how can it be managed? Well, this is a pending issue, which will be very linked to the answer of item related to the syndromes that we will most frequently find. So this is something that we cannot answer so far. So currently we have a lot of questions, some answers. We are optimistic to have more answers in the near future. I would like to thank you for your attention, and the references that I use can be found using this QR code. Thank you so much. We have some time for updates. This COVID-19 area and post-COVID-19 is a moving field. We have updates all the time. So we organize our webinar so that we have some time for updates on the talks. So I would like to invite Robin to draw a few words on updates from your talk and recent data, and then we will move to Q&As.
Thank you so much. Yes, we're using our data collection really as a living laboratory. As you say, we're learning in real time about this disease. Our next study is focusing on breakthrough infections of those who've been fully vaccinated, then get a COVID diagnosis. We will be comparing that cohort to those who are unvaccinated and what their trajectory of symptoms are, which will shed further light on long COVID symptoms. To what extent do those two groupings differ, whether you have been vaccinated or not, and also allow us to peer into the population of those who are experiencing a breakthrough infection. Is there anything we can discern from that cohort in terms of age, gender, geography, prior symptoms and comorbidities? And of course, when we do conclude that study, which will be in the coming month or two, we will make it freely available and disseminate it.
Great. Thank you, Robin. So we have some questions from the audience. Well, the first one is related to, well, can you clarify the difference between fatigue and weakness?
I think
Ryan, would you?
Yeah, I'm happy to take that question. And so fatigue is the ability to sort of maintain one's ability to do work over time. And so it's a sort of a time function, right? So when somebody fatigues, the muscle strength, their ability to do that work initially is fully intact. And what happens is over time, they become less and less able to maintain that level of work. And so that's what fatigue is. And the process of that happening over time is often called fatigability. Weakness is the inability to have the strength to do the work to begin with. When one is weak at one's initial effort, there is less work, less strength, less ability to do whatever task would create weakness than in normal circumstances. When patients describe these things, though, it sometimes gets confusing. Patients may describe fatigue as weakness or weakness as fatigue. And so when talking to patients, sometimes it's good to sort of remind them, do you find that it's hard to initiate movement? That you find it's hard that you're weaker than you used to be, right? Or you find that you're just sort of tiring out, that you're as strong as you normally are, but you just can't maintain that at that rate for a long period of time. And so those sorts of questions can sort of help clarify it when one's talking to patients. All right. There's a second question here. How do you differentiate classic fibromyalgia from fibromyalgia secondary to COVID? Would you like me to take that, Daniel, or do you want to give that a crack?
You may start this. It's interesting because there's a link with fatigue, and it's true. Please start.
All right. So the idea of classic anything is always a challenge, right? Fibromyalgia is a description, and whether that description comes in the context of a temporal cause or not doesn't make it any more or less fibromyalgia. Fibromyalgia, the definition of what it is has changed over time, but the elements really are widespread pain and with the addition now of sort of fatigue, mental alterations, and sleep, unrefreshed sleep. You can't really differentiate it. There was the old term, this idea of secondary fibromyalgia coming from something else, but really we aren't able really to ever understand the cause of fibromyalgia. Causality is very difficult, but temporality is not. A lot of times something will happen within a short period of time before the fibromyalgia comes, and then we sort of attribute it. And in this case, many people are developing the fibromyalgia symptoms after a COVID infection. The COVID infection seems to be a trigger for what comes, but it's hard to know if it's the cause of that fibromyalgia or if there are other factors that were underlying all of this and latently and were set off. But in the end of the day, we use our best guess to try to attribute cause or temporality to differentiate between fibromyalgia that just sort of happens without a clear reason and those that seem to be related to something that preceded it.
Yeah. Thank you. It's nice there's a term, comorbid fibromyalgia. There's a nice review from Serge Perrault, who will be speaking later, and who could also address this interesting point. So that using comorbid, there's no cause and effect presumptions, and you just attest that this patient has symptoms of fibromyalgia correlated or temporarily related to a certain infection. In clinical practice, it's easier actually, because you talk to patients and you ask if they had symptoms before, if they were fibromyalgia patients before the infection or if they started afterwards. It may be tricky in cases where symptoms start a long time after the infection. So that's a point that we don't have any final word on how to classify these patients, because if a patient had COVID 1 year ago and starts having fibromyalgia symptoms insidiously right now, would that be related or not related to COVID? That's an open question too. But in pragmatic terms, patients have symptoms. We will treat them symptomatically as we usually do, and we should use the framework we usually. We don't have evidence to do that, but in clinical practice, what we end up doing is that you treat them symptomatically and use the framework that we use for fibromyalgia and try to help these patients, although there's no formal evidence. And as I mentioned, most of what we know is still based on symptoms. We had a lot of interesting data from Brian and trying to dig into markers, but still most of the data is just related to symptoms. We have to examine these patients and try to fatigue. There are patients who have fatigue and they actually have weakness. Some patients, at least in some cultures, people use fatigue as an umbrella term. Some patients with fatigue are having pulmonary problems with oxygenation and ventilation. So once we start examining these patients, as we're trying to do, we're going to have more information on try to dissect what is what. And it's going to be, I hope it's going to be easier to classify these patients. We have a third question. In regards to pain symptoms reported, was there a breakdown of the symptoms reported, for example, proportion of neuralgia, myalgia, or headaches? Do you have information on that, Robin? Would you like to
Yes,
share with us?
certainly. Since we're working from claims information, we're looking at diagnostic as well as procedure codes. So there are distinct diagnostic codes that allow us to differentiate between those different conditions. In terms of other and unspecified soft tissue disorders, which is where neuralgia and myalgia sit within that umbrella, the myalgia was approximately 46% and the neuralgia was 6%, with other chronic pain coming in at about 35%. Fibromyalgia was approximately 14%. Headaches is outside of that diagnostic condition, is sort of categorized more with migraine and headaches. So that was a different percentage, which was under 2%. I should mention, though, with respect to fibromyalgia, given the earlier questions, because we're working with longitudinal data with de-identified patients, as mentioned earlier, we excluded anyone who previously had a fibromyalgia diagnosis prior to the index date of their condition, and then really just look prospectively in that 30-day window and beyond to try to at least isolate. But as Brian and Daniel have mentioned, sometimes it can be difficult to really attribute specifically the cause of that fibromyalgia.
Thank you. That was a great answer.
Thank you.
There's a fourth question here. The pain after infection with COVID-19 is mostly non-specific, except for neuropathic pain. How common can myofascial pain occur de novo after COVID-19? Any thoughts, Daniel?
Yeah, we as from the clinical experience, we see that myofascial pain syndrome being musculoskeletal pain with trigger points and referred pain, they are very common in these patients, as they are common in any type of chronic pain patients. So these patients who have more myalgia, more muscular pain, quite frequently, if you examine them, you'll find myofascial pain syndrome, and it has may have implications to treatment. It's also, there's the fifth question on that's also clinically related. I wonder if fibromyalgia symptoms post-COVID could fade over time or long time. Could you please comment on that? We see patients getting better, luckily, and some patients have symptoms getting better with time or with treatment. Something that we have not really mentioned here, which was supposed to be in the first part of this webinar, is that when we examine these patients, we find it's being recognized in several papers now, a relatively high frequency of dysautonomia. So some patients, in my experience, maybe it's biased because I'm a neurologist, maybe these patients I'm seeing a proportion of patients, but the patients who arrive to a neurologist, they have a high proportion of dysautonomia with either tachycardia, postural orthostatic postural tachycardia syndrome, or with orthostatic hypotension. And several patients, when you treat these dysautonomic features, sometimes with simple measures, just like using compression socks or doing some adjustments in their salt intake during the day, they improve of their fatigue. There are some studies showing that even these patients have altered blood flow compensations when they move from one position to the other. And some patients refer fatigue, and some patients have some headaches. It's called coat hanger headaches. It's known from the Parkinson's disease literature. And some patients with headaches improve after treatment of fatigue, of orthostatic hypotension. So something that's worth mentioning when we talk about non-specific symptoms and this type of thing.
I think I would like to add something to those questions. So in regards to myofascial pain, one of the things to keep in mind is that it is poorly understood by the people who have it and poorly collected by the instruments out there. So when people are using, especially for initial COVID research, sort of patient-reported outcome measures and diagnostic coding, myofascial pain doesn't do so well. Not all practitioners see it, and most patients don't even understand what it is. And so the idea that there's going to be good numbers about how that's influencing COVID at this point in time seems problematic, just because it's not really that well defined. Instead, you'll see terms like myalgias, which will incorporate at least a large portion of myofascial pain, but won't get you to that specificity that a clinician really wants to know in sort of how do I treat patients. In regards to fading over time, the data I showed about post-viral fatiguing disorders, I think is pretty instructive. There's a great, 30% of people will have symptoms immediately afterwards, but those numbers fade in time to less than 10%. And so you can anticipate that a large number of people who have fibromyalgia type symptoms will probably follow that pattern too, getting better over time, over about a year's window. However, that's not everybody, and that you can't at this point predict who those people are going to be. And so other work in fibromyalgia, especially the work done by Fred Wolf, has shown that it as a disorder itself waxes and wanes over time. And so how much of it is going to be people getting better? How much is it that, the symptoms themselves shift and aren't constant? These are things that will have to be considered in trying to understand the long-term consequences of pain in COVID patients. So I think we have people are asking lots of questions here. Sixth question was, can you please comment about the pain symptoms, fibromyalgia associated with the COVID vaccine? Anyone want to give that one a
Sure. I'll jump in on that, just in terms of a possible study design. Just though, as a follow-up with the fifth question, whether it fades over time, one thing that we can do is, our study period was February 2020 to 21. We can look at that same cohort who developed fibromyalgia, or at least appeared with symptoms or got treated for the first time, at least from our repository, 30 days out from diagnosis, to see how much that persists beyond the study period. That would be another interesting piece of information. With respect to the COVID-19 vaccination issue and the possible association or correlation, that's something that we will certainly put on our Blackboard as a possible view as well, where we can identify those who have been vaccinated to construct a study design that will see to what extent there are any of these same symptoms that are arising after that without the diagnosis.
I would like to add, with millions and millions of vaccines given to date, there have been certain types of complications that have sort of risen to the top. Kids do get a inflammatory myopathy, some of them. There is a neuropathy that is associated post-COVID vaccine that has been reported and seen, but there's not a lot of reporting about fibromyalgia occurring after vaccinations, and not in the media, not in the scientific literature. And so it does not seem to be a major issue. And if it was, it would have shown itself at this point in time.
Good.
All right, here's another one. Would it also be a challenge gathering data about fatigue if the long COVID patients may have initially tried to push through rather than following more recent pacing advice? I guess anyone else want to take this, or I can take it if. All right.
Go ahead.
All right. So the beautiful thing about collecting fatigue kinds of measures is whether, even if it's a subjectively reported measure or an objectively reported measure, they're all the same no matter what the participants do. Right? And so actually collecting the data won't be actually affected by the behavior of the individuals. The way that the data is collected is always the same. Will it change how the outcomes are? Will people who push be different than those who don't push or pace earlier? Those are open questions. I imagine that you'll have all sorts of outcomes. There'll be people who push and recover. There'll be people who push and do worse. There'll be people who pace and get better, and there'll be people who pace and don't get better. And how that will turn out will be a difficult thing to study, because it's very hard to really understand people's behaviors at the time right after the infection. And so it will be interesting to think about that, to understand how adopting these strategies might impact long-term outcomes. But I don't think that we'll be able to answer that with study designs that are out there currently.
Great. Thank you, Brian. We have another question. What we see in our experience is that myofascial pain is more associated with the low mobility of these patients, especially after prolonged hospitalization. What's your experience? Well, as Brian mentioned, myofascial pain syndrome is still restricted to some areas. There are some areas that study that a lot, some that don't, and some region of the world where it's mentioned and examined and considered a lot, and others not. Well, in Brazil, we are in, I would say, myofascial pain syndrome friendly country, where it's really taken into account in clinical practice, and any type of mobility will cause the findings, the clinical findings that we see in myofascial pain syndromes, and taking that into account when treating patients or doing rehabilitation is important, as it is for any type of chronic pain syndrome or musculoskeletal pain syndrome. I would just, I think, I'm not sure that patients who had COVID have more myofascial pain syndrome. I think it's just as the usual expected finding, nothing that exceptional, really.
I would say that there may be some insight coming into some of those questions. There is a lot of use of wearable technologies that sort of are able to quantify movement in real time in real lives, and the sort of the application of that technology to COVID, I know is part of a lot of the larger research studies that are coming down the pipe. And so we may understand better how movement patterns impact outcomes in our participants. I think that your experience is probably correct. And the low movement people are going to have higher issues with myofascial pain, probably because of a bidirectional relationship between the two. And so I would imagine that your experience will turn out to be validated.
Great. And that's still on myofascial pain syndrome. So 9th question, is there any correlation of cytokines being implicated to the post-COVID myofascial pain syndrome pathophysiology? I don't think we have this information for any type of myofascial pain syndrome so far, but maybe not yet for COVID related. There are some reports. There's a large study from Caesar who gave us a very nice speech on the first part of our webinar on his publication in Pain with Lars Arndt Nielsen's group, showing myalgia or myalgia during acute infection, predicting more muscular pain after the patients are leaving the hospital. But it's not based on the examination of patients. We cannot attest that they had myofascial pain syndrome, but I guess most of them might have, or might be considered as having myofascial pain syndrome. So, but something that we're gonna, their group are doing a lot of biochemical and inflammatory measurements. Maybe we're gonna have some information on that in the near future. Okay. So
we're in the last minute here of our meeting. Again, I would like to take the time to thank all of the speakers that came today, Robin and Ali and Daniel and me, for presenting to your group today. Thank you for all your wonderful questions and being a great audience. And feel free to reach out to us with any additional questions. You can reach out to Daniel or I, and we'll be happy to relay questions to Robin and Ali as necessary to help answer any questions that may come up after this session is over.